3, go.
This is a 31-month-old male with a complex medical history consisting of a left congenital diaphragmatic hernia, status post repair, double outlet right ventricle with mitral atresia, status post central shunt ×2. He is event dependent, status post tracheostomy, status post Nissen fundoplication and GJ placement due to GERD. He has a history of seizures and a history of 2 VA ECMO runs, one postoperatively from a CDH repair and one postoperatively from his first shunt placement. He presented to the EC for desaturations and increased work of breathing, as evidenced by increased O2 requirements at home, nasal flaring, suprasternal and subcostal retractions, and he was brought in by his mom, who is the historian. Differential diagnoses will include upper respiratory infection, shunt stenosis, infection, heart failure, pneumonia, and RSV. The plan will be to admit him to the CVICU for further monitoring and care due to his complex medical history. From a neuro standpoint, he appears to be at his baseline, so we will continue his home regimen of Keppra twice a day and continue to monitor for any further issues from a neuro standpoint. From a respiratory standpoint, we will maintain adequate oxygenation and ventilation, achieving SAT 75 to 95% with the following vent settings. Per his home trilogy, he will be on a rate of 25 with a PEEP of 8, pressure support of 14, and an oxygen flow rate of 2 liters. We will obtain a sputum culture on admission, a respiratory viral panel, and a chest x-ray. We will continue his albuterol Q4 PRN and continue his Flovent twice daily. From a cardiac standpoint, he will be on continuous hemodynamic monitoring per the CVICU guidelines. We will consult cardiology for any input or further recommendations that they might have. We will get an echo on admission. We will continue his daily aspirin for shunt prophylaxis, and we will continue his home diuretic therapy consisting of Lasix every 12 hours, Diuril every 12 hours, and spironolactone every 12 hours. From an FENGI standpoint, he appears to be at baseline, having no issues from there. We will continue Elecare at 55 mLs an hour via his J-tube for 20 hours a day. We will continue his GI prophylaxis of Reglan 3 times a day, lansoprazole once a day, and ranitidine twice a day. We will also obtain lab work, a CMP, MAG, FOS, triglyceride on admission to look at his electrolytes and make sure there are no issues there. From a heme standpoint, there's no active issues. We'll get a CBC and check his H&H and his platelet count as well as his white count. From an infectious disease standpoint, we'll continue to monitor for fever. No blood cultures at this time, but if he becomes febrile, we will obtain a peripheral blood culture and start antibiotics. So plan for now would be to admit for 48 hours with an anticipated discharge home in 48 hours with continued home nursing and his medical daycare. And as of right now, there are no further needs identified at this time.